I'm going to introduce our speaker for today. You're very welcome to the Geary seminar today. Today, I'm absolutely delighted to welcome Professor Alistair Nichol, who also happens to be a Geary Fellow. Alistair is Chair of Critical Care Medicine at UCD, and he's also Director of Irish Critical Care Clinical Trials Network. He's raised a large number of peer-reviewed grants worth over 50 million in locations as varied as Ireland, Europe, Australia, New Zealand, and Canada. His publications are stellar and include the New England Journal of Medicine, Lancet, and the Journal of the American Medical Association as first author. A reminder that, as per usual, we will take questions through the Q&A format at the end of Alistair's presentation. And so without further ado, I'll pass you over to Alistair for his seminar today, which is on Irish critical care, pandemic preparedness when the rubber hits the road. So Alistair, over to you. Thank you.
No, you're very welcome. Thank you very much for that introduction. And look, I'm delighted to be here. I'm delighted to have the opportunity just to maybe share some of what our team and our community has been up to. And the only other thing I'd say is there is a very small chance my phone could go off because I'm covering the ICU today as well. So, but a colleague has kindly stepped in. So please apologize if that was to happen. So what we're talking about is pandemic preparedness. And I suppose there's really a few themes I would aim to cover today as well. How did we get here? Recent pandemics and some of the preparation work we've done. And then go into some of the projects that our team and our group have undertaken to answer some of the evidence gaps that became obvious. And one of them is an observational study called Sprint-SARI. And really, what information did we need to know quickly? But really, what information do we need to know definitively? Because when we go to treat patients with a new disease or a new illness, we really want to get answers quickly. And we'll talk about a global platform trial, which was a new way of getting this information in a really rapid way. And some disclosures at the start. I have funding from a number of governmental funding agencies, and I did some pandemic-related consultancy work for the University of Oxford on an Horizon 2020 project. And again, I suppose the biggest disclosure would be that all of the work I'm going to discuss today has been done by a huge number of people over a huge number of years, and really is on behalf of our clinical trials group and the Irish Critical Care Clinical Trials Network. So how did we get here? So as they say, there's always one, and for the last number of years, that has been me. I've been involved in pandemic research since 2009. And with a good friend and colleague of mine, Steve Webb, who we wrote this paper 3 years ago, and he gave the plenary session at the American Critical Care Society meeting. And really it was called Bending the Pandemic Curve. And this is before bending the curve would be common parlance that everybody in Ireland would know. And this was about how we could improve decision-making in critical care research in particular. And at that time, we talked about really the three large existential threats that could kill 5 to 10 million people. And among those was a nuclear conflict, a stellar collision where an asteroid or some foreign object was to collide with the Earth. And again, the one that was probably the most likely but was not getting a huge amount of attention was viral illness of pandemic potential. Now, the illness we had in mind was flu virus, and we ended up with a coronavirus. But again, unfortunately, we have seen that a respiratory viral illness has the potential to kill huge numbers of populations, with figures estimated to be above 5 million deaths, unfortunately, but the figure is likely much, much higher than that. So, well, could we have expected, or was there a reasonable likelihood of a pandemic flu happening? And the answer is yeah. On average, if you look back over the last 250 odd years, you can see there's an influenza pandemic roughly every 23 years. And some of them are bunched together, some of them are more spread out, some of them are more significant and last longer, like for instance, the Spanish flu at the start of the last century. And if we look back to 2009, which is 12 years ago now already, so we're halfway through our next period for another potential for a flu pandemic. So pandemics are cyclical things, unfortunately. And look, the chances of them happening are becoming more common, not less common. This actually was a slide from 4 years ago. And again, it was interesting because only at that time were communities in Southeast Asia regularly wearing masks in public. But again, since then, we've seen that has been common the world over. There are always emerging and re-emerging infectious diseases with pandemic potential. And this sort of map was just to show that they occur in many different places. But the development of modern air travel and the ability really for a human to be from nearly any place in the globe to another place in the globe within the incubation period for most viral illnesses means the potential for global spread is higher and only getting more significant. I bring you back to the H1N1 pandemic back in 2009. So it started in Mexico and then it spread around the world. Southern hemisphere winter first and then up into the northern hemisphere. So I was working with my colleagues in Australia at the time, and this is Steve Webb led this publication. And at the time, we described the H1N1 impact on critical care services in Australia and New Zealand. And again, look, these were the pandemic curves from the various states and territories in Australia. And again, these are now pandemic curves that everybody's familiar with. They've been on the 6 o'clock news for as long as many of us can remember. And we described the attack rate, the number of people who were affected, the impact on resources, unfortunately, the number of deaths that occurred during that wave. And so this information was highly useful for the Northern Hemisphere to prepare for the oncoming winter. But really, what we had hoped to do was to conduct clinical trials at that time. So this is a slide from Prepare, and Prepare is an EU-funded FP7 program that was established in 2014 for pandemic preparedness, and it described the situation at that time. So a pandemic comes, there's the waves sweep across the country, and sure, there's a public health response that we've all seen. There's a preclinical response, what happens very rapidly as well, where samples are taken, viruses are isolated, they are described, and that information is put out there. But the clinical research response, and as a clinician, that's a component that is of significant interest to me, is how it actually affects the patients we look after. And that has been lagging. And in that previous publication I talked about, we would have hoped to have done a clinical trial, and we had hoped to do a clinical trial assessing whether the use of steroids were useful in viral pneumonia or not. And we were unable to. And likewise, it's been estimated that during the H1N1 pandemic, lots of people used oseltamivir for patients with flu, but we still don't know if it works or not. And there would have been enough patients who were sick in ICU in nearly any one day during the peak of that pandemic that we could have answered that question. But we just weren't in a situation we weren't in a position to answer those questions. So this is where the Prepare grant or the Prepare collaborative framework hoped to get us to. It's a stage where we weren't caught like we were in 2009 as clinicians on I think for under 100 patients globally that were randomized into ICU trials at that time. But we want to get the clinical research response kicked in quickly to answer questions at the bedside for clinicians. So I'll just step back at that for a second, just talk about the big picture. So when we think about pandemics, and especially even from a very focused view of, say, me being an ICU doctor in a hospital, we have to think obviously about the community where all our patients and our colleagues who work with us in the hospital come from, the ICU staff who have to come in every day and care for these patients as well, the families, and unfortunately in critical illness, it's quite commonly a substitute decision maker or a relative who makes a decision on behalf of patients because of their illness, they're incapacitated. And again, we have to think what the patient would have wanted or what their previous wishes would be. So we have to take all of these things into consideration as well. So as part of that Prepare grant, I worked with a super group of people in University of Western Australia, Cardiff and Oxford, and we wanted to tap into this. And really, where the rubber hits the road in the ICU of meeting family, public, patient center is the consent process. This is where we sit down and discuss with patients and other relatives about trials, the risks, the pros, the cons, the processes, etc. So we did a rapid sort of systematic review, see what the literature said. And look, the potential research participants, their families, clinicians, researchers are broadly accepting of alternative methods of obtaining consent for emergency research. And when I say alternative methods, I mean methods where we can't speak to the individual directly. And what we find is actually, it was the regulators and the ethics committees were a bit more skeptical, and the patients and their families tended to be a bit more pro. And I suppose that is the balance that the regulators and ethics committees, are charged to protect. So we actually did some work where we actually set up focus groups and looked at members of the public who could be patients in the future. And we asked them about the various attitudes about pandemics, pandemic research, what questions they thought would be important and what researchers should be asking the public in the advance of that pandemic. And we created some public facing documents. And the whole point of this was actually to help us to design an international survey. Because if we were going to conduct a trial in ICU patients in the future, we thought it'd be of great value to know what the public in those individual countries' views were on a number of related topics. And I'll go through a few of them now. So I think it's important to say, so we did this survey and we did it in the Southern Hemisphere and in the Northern Hemisphere. And we did it during their respective winter periods when, people would have, either themselves or family members would be sick with the flu, and that would be cognizant, even though it wasn't a pandemic that year, but they would be thinking about flu infections. So, 82% of the respondents, who were 6,800 people, thought it was important to do research during the flu pandemic, and 3/4 thought that special rules should apply to facilitate that research in a timely manner. And we actually put to the patients, actually in a general practice, but also in an ICU setting, but I'll just talk about the ICU setting, 2 different scenarios. So the first scenario was sort of what we call comparative effectiveness research, so pretty low risk research where there is a treatment that is well known and there's maybe an alternative or no alternative, and really nobody knows if it works or not, but its safety profile seems to be reasonably well established. And we asked patients, so potential patients in the future, would they be interested in taking part in that research? And so here are the results. So let me just broadly talk through it. So if you go from left to right, so the blue on the left said strongly disagree, the red disagreed, the green were neutral, the orange were intermediate, the mauve were agreed, and the red the mauve strongly agreed and the red had no opinion. And the countries are listed on the side there as well. So what we can see is the patterns across the countries are broadly similar. And like under 10% of patients either disagreed or strongly disagreed. The vast majority were either neutral or in favor of taking part in low risk research. And in particular, that using the surrogate decision member of either their family could consent on their behalf. And there were a number of different models that people were split by either waivers, either we ask another member of the family, and in some jurisdictions, they allow physicians to provide consent on patients' behalf as well. So we went through actually a higher risk model because in a future, so like that previous study could have been the oseltamivir or it could have been the steroids. But in a pandemic, we might want to test more novel agents, or actually agents that were developed for other diseases, and to see if actually they are of use during a pandemic. And in this model, so the results were broadly similar. Now, there were a slightly higher, but still very small group who disagreed or strongly disagreed. By far, the majority still were in support of this sort of research, and were in support of the methods of consent we currently use. And like, so I have to say that information was really useful for us for planning ahead. It allowed us to be pretty confident that we weren't getting out over our skis, and that our patients and the community were supportive of the methods we would be using if a pandemic was to arrive. As part of that Horizon 2020 work we did with Oxford University and Foundation Murray, we actually looked at how could we help funders in the future. And again, I think there were a few things that came out of that work that, you know, I think things had to be done early. If there was funding being put in place, it had to be early. Research had to be integrated into clinical practice, because when it hits the proverbial fan, everything else gets dropped when clinicians are so busy looking after their patients. So it had to be already integrated. And we actually had to have partnerships facilitated in advance. And we had to agree what triggers would be put in place for us to either conduct our studies or pivot our studies, as I'll talk about later on. And again, there are a number of other programs with public engagement ongoing at the moment and being developed. So there's patient panels of patients who have been in our ICUs or have had COVID, and to get their views and their families' views about the research and research processes that we're using. So to maybe then talk about some of the scientific aspects. So what information do we need to know quickly? And to this, I'll talk about the SPRINT-SARI study. So SPRINT-SARI stands for the Short Period Incidence Study of Severe Acute Respiratory Infection. And it was a global observation study, which was actually, it was led out of Monash University in Australia initially, and now it's been led out of Oxford University and ISARIC. And the problem before is we went back to H1N1. So we collected that observational data I talked about. And we had various definitions for this and that. But the problem is we went to compare it with the Irish data or the British data or the French data. Everybody had collected slightly different things, and it was hard to compare and it was hard to benchmark. So the solution was to develop in advance. So we took the best data forms that had been used in the H1N1 pandemic, and we then adapted them for a future as unyet known pandemic. And again, this was then supported by the World Health Organization, and then we aimed to get ethical approval in countries to conduct the study. So, like for instance, in the hospital I work in Dublin, St. Vincent's, we got this approved in 2015, and for every year we collected data on patients with the flu or respiratory infections, just for a week a year, to use the forms, use the database to practice. And the idea would be that if a pandemic ever came, all the approvals were in place, it was ready to go, and we could immediately pivot and collect this data. So as of about 10 days ago, and globally there were over 400,000 patients who had entered data from over nearly 800 sites from over 63 countries. And that's a huge credit to Laura and Shrin from Oxford for organising that, and Steve and many others in SPRINT-SARI from setting us up at the start. In Ireland, we actually have over 2,000 patients in this, and we have a separate Irish database where actually it's a resource for Irish researchers, and we have 1,300 patients in that and nearly 500 from ICU in 18 hospitals around Ireland. Well, so what sort of data do we collect? So these charts would look at how many patients are male, female, what ages they are, how many of them died, how many are in hospital, and how many of those reports, and we sent around the bedside doctors and nurses. So this information was available to them. We can see really the three peaks of the Irish pandemic waves at that stage. And again, the number of patients, discharges and deaths. And so, but there was other information that we could use, and because we had our own Irish data set, we were able to benchmark it globally. And again, so this slide is just to show the idea rather than go into the specifics. So on the left, it's the global data, and on the right, it's the Irish data. So we were able to look at treatments our patients were getting and see what portion of our patients were getting these treatments and how that compared to treatments that were being given in other locations in the world. So it allowed us to benchmark our practice. In addition, these are hospital in sort of light purple and ICU in the dark purple lengths of stay. And we were able to look at the length of stay of our patients with globally on the left and Ireland on the right. And a nuance of the Irish database was we had quite a lot of ICU patients, so we were sort of ICU heavy, and that's because I suppose an ICU network was running it. But I think which was reassuring, so global on the left, Ireland on the right. I'm sorry, there's two different colors. If you look at the bottom sort of hill in green on the left and brown on the right, it's the mortality rates. So even though we had a reasonably sick cohort and a lot of them were ICU, our mortality rates in Ireland were actually quite favourable. If we look at just maybe how the Irish effort compared globally, and we were the 12th highest recruiting country, which is pretty amazing considering the size of our country. So I have to thank everybody that took a part for the huge amount of work. The Irish report and the global reports are updated regularly and they're available publicly. So I might talk about a study that was developed well in advance of this pandemic. It was led by a guy called Ken Bally from Edinburgh University, who had been central to the Sprint SARI work. And he had an interest in collecting biological samples, and as did we. And there has been, so using a data set very like the Sprint SARI data set, they collected genetic samples from critically ill patients who had COVID-19. And so this study is running in Ireland and in the United Kingdom at the moment, and there's plans to spread it out larger. But I suppose what this study showed is there had been a promise that genotyping patients in ICU would be useful, that we might find markers that would predict outcome, or even markers that might be potentials for novel therapeutic agents. And that potential has never really been realized. However, during COVID, and for the first time, everybody got sick with the same thing, and a huge number of patients presented to ICUs with the same illness. And it was a very homogeneous population. And up until that point, ICU had been very heterogeneous. Some people had pneumonia from different causes, and this was the first time it was a sort of a uniform population. And this is the thing called a Manhattan plot. And I suppose what to say here is the things above the red lines were sequences or areas that highlighted as being associated with mortality of patients with COVID-19 admitted to ICU. And so not only could this help identify patients at higher risk of death, it also suggested potential therapeutic targets for novel or repurposed agents, which became important in COVID-19. And a lot of these markers suggested reasons connected with the inflammatory system, or potentially over response or hyper response of the patient's inflammatory system to the viral pneumonia may be important. So I think Sprint SARI did exactly what we hoped it would do. We never knew if we would be using it in anger or in war rather than peace. And it seemed to perform pretty well and provided information to clinicians at the bedside that was clinically useful, as well to public health authorities and to government's planning. So finally then, maybe to talk about Remap Cap, which is the global platform trial. And this was to test novel therapeutic agents. So a traditional randomized controlled trial, and a randomized controlled trial is the gold standard method we use to test whether a treatment we serially test single hypothesis. So we organize a whole trial, we randomize patients, and again, I'll use 3 examples here for community-acquired pneumonia. So which antibiotic is best? We do that trial, we wait to the end, we get an answer, and then we ask another question. So macrolide, which is another type of antibiotic we commonly give in combination, Should we give a short course on it or a long course? You'd ask that question next. And then finally, should we use steroids in these patients as well? So it's a long, slow, cumbersome method that only asks one question at a time. But the Remap design, it's self-learning. So Remap stands for Randomized Embedded Multifactorial Adaptive Platform Trial. And I know that's a bit of a mouthful. But what it aims to do is determine a group of patients, ask multiple questions at the same time. It collects outcomes during the trial and feeds that back into the trial so that the trial learns as it goes along. And you can see how a model like that could be particularly attractive during a pandemic. But let me go through that in a little bit more detail. So at the pre-trial stage, so you have to plan, right? You have to plan what your trial is. And we decided we look at community-acquired pneumonia. And one of the reasons we decided we look at community-acquired pneumonia is patients with a new pandemic infection present pneumonia to ICUs with pneumonia. And essentially, it is the canary in the coal mine for a new virus of pandemic potential. Now, however, we wanted to ask lots of questions about community-acquired pneumonia. It's a huge cause of admissions to ICU. It's a huge cause of mortality. And many of the patients with infection or sepsis that you hear about have pneumonia. So there are lots of questions we can continue to ask in peacetime, but the idea is we were also ready to pivot in the case of a new viral pandemic. So we included patients with community-acquired pneumonia. Now, you have to randomize patients into a randomized controlled trial, and that's how we can determine inference. But Remap Cap uses a response adaptive randomization, which is particularly advantageous during a pandemic. So as the system learns, if one treatment seems to be more beneficial than another, a higher proportion of patients will be randomized to the treatment that is looking beneficial. So you can see how that, I mean, just on the face of it, that would seem more ethical. As the trial learns, more patients get the treatments that are effective, rather than actually, even though we knew 2/3 of the way through, waiting to the very end to announce this. And it's done in a manner that clinicians at the bedside don't know. It's really important to embed these trials into routine clinical practice. And we did a number of things to make it as seamless as possible for the doctors and nurses looking after patients to enroll them into the study, and for the various treatments to be made part of the daily cut and thrust of treatment of a busy ICU. As I said before, patients can be randomized into multiple, what we call domains. But and a domain would be like, for the example we give at the start, it could be either what antibiotic, what macrolide, or steroids, yes or no. And you can see in this example in the blue that you can have multiple different combinations of interventions. And the idea is that you find the regime. So which of these is the best? Is it, antibiotic A, short dose macrolide, and no steroids, say? I mean, is that the ideal combination or regimen? So the trial can tease these things out. And it's really important during a pandemic to find out these interactions. Again, the data is collected regularly. And for our community-acquired pneumonia trial, we used outcome in 90 days. But for a pandemic, we couldn't wait 90 days to get that information. We needed that fed back into the response adaptive randomization. We needed answers for our patients quicker. So we picked 21-day organ failure and mortality, so we get answers quicker during the pandemic. This information is integrated regularly. So during the height of pandemic, the model was being run every month. And either, you can see in the bottom right-hand box, the trial could stop if we showed something was superior, something was inferior, or something was no different. But also in the gray box on the far left, and as you'll see happen during the trial, we actually were able to integrate external information from other trials to inform decisions. 2 weeks ago, there were 8,669 patients who were randomized, and of those patients, they were randomized into 15,528 interventions. Just over 7,000 of those were patients with COVID, and 13,000 of those interventions were patients with COVID. So over 50 interventions were tested in over 330 sites. So it's a huge endeavor. So let me just briefly show you what the intra-pandemic. So this is the peacetime model we were running before COVID came. So we looked at antibiotic combinations. And again, clinicians would be unsure which of these is best. So we aim to test that. The macrolide, as I talked about, is a short course better than a long course? We just do not know. And steroids, that has been a question that's been hanging around for decades. Should we give patients with pneumonia steroids? Should we not? Should we give it a fixed dose, or should we give it only if they're shocked? And again, this peacetime model aimed to answer that. And again, we were looking at ventilation, which is a central point of ICU care. What is the best strategy? But we also had a module which we actually had ready but hadn't yet started, looking at oseltamivir. And as I said, that was a huge question of flu. Should we use oseltamivir or not? And this domain was sleeping, ready to be activated during the next seasonal flu winter. But events overtook that. So let me talk about the pandemic model, so the wartime model, and what we found. So in brief, I'll just go through a few of them. So steroids, should we give steroids or not? We were already recruiting patients with community-acquired pneumonia into either no steroids, fixed dose steroids, or shock-dependent steroids. And the day we went into war mode, we were able to randomize patients with COVID-19 into this steroid question. And we were able to get answers, start recruiting immediately. There was no downtime. And essentially, there was a large UK trial that reported in June of 2020 that steroids were beneficial in ward patients. So we integrated that external information. We stopped our trial and we analyzed and published our results. Now, our results are different because we're mainly looking at ICU patients, so it's a different cohort, but we find exactly the same thing. So we published these results. If you look at the colored, it's a Kaplan-Meier graph which shows death at the top. So the higher the curve goes, the more death. And if you look at the boxes with the red and blue, more red is blue, more sort of pink is organ failure, and light blue and dark blue are organ recoveries. So if something is better, you see less red. And what we find is that steroids were more effective, or 93% probability of being effective against no steroids in ICU patients. So this was incorporated into WHO meta-analysis published in the same edition of JAMA and became the WHO and the HSE standard of care for patients with COVID-19. We looked at antiviral agents, and these had become very contentious at the start of the epidemic. Does hydroxychloroquine work? Leponavir, ritonavir, which is a HIV drug, is it effective or not? Again, the recovery trial suggested that hydroxychloroquine wasn't beneficial, and they stopped that randomization into ward patients. We analyzed our data, and we found in ICU patients, and you have to bear in mind, ICU patients are different, that actually hydroxychloroquine was likely harmful, and leponavir, ritonavir was not effective. So these answers stop the use of these medications in ICU patients. It's just not done anymore. And we've adopted a new domain, antiviral domain, looking at ivermectin, which has become super controversial at the moment as well. Immunomodulation. So the antiviral agents try to kill the virus, but maybe the problem in the patients in ICU is actually the body's over response to that virus is actually the problem. So we tested a repurposed drug, which was called tocilizumab and sarilumab, which are IL-6 receptor antagonists. So these were arthritis drugs, and they can dampen down the immune response. And what did we find? We found those drugs significantly reduced death and organ failure at 21 days and reduced the length of time in hospital significantly. So again, this was a huge finding which has been incorporated into guidelines and is now the standard of care. We looked at anticoagulation. People know that COVID seems to be associated with clotting and thrombosis. And the question was, well, hey, if that's the case, if we anticoagulate patients, is that good? And many, many people were doing this around the world. What we found was, well, we said, let's look at ward patients who are a little bit sick but not dead sick, and ICU patients who are very sick. And what we find is in ward patients that actually anticoagulation is beneficial. And even though you have a slightly higher risk of bleeding, overall you have a less chance of getting sicker and requiring ICU, which is beneficial. But really interestingly, I've got the wrong slide at the bottom here, so I apologize. When we looked at the ICU patients, it was different. Anticoagulation was not beneficial and was likely harmful. So that's a really important finding. And again, it's to stop the use of anticoagulation in this patient group where clinicians were doing it with the best intentions, but were likely causing harm. And there's a number of other interventions we're looking at. Convalescent plasma, which was the antibodies, so the blood containing antibodies of patients who have recovered from COVID-19 given to other patients who are sick. And we just put a result out that didn't appear to be effective. We looked at antiplatelet agents because many people have been given aspirin to these patients as well to find out the answer. And this is to say there's a number of other domains in COVID that we're looking at other treatments to see if they're effective or not. So I'm just going to start to wrap up. So you can see a remap design for a pandemic is pretty useful. You can just switch it on immediately. There's no huge long startup period. All the ethical and pre-approvals are in place. There's a master protocol which governs the whole trial. But as you can see, we were able to add new domains or new interventions in and take other ones out as the pandemic evolved. And we were able to have a peacetime model, answering important questions in pneumonia, as well as a pandemic model. And again, I think Remap Cap has performed better than we would have hoped at the time. We were able to answer more questions in Remap Cap for patients with COVID in the last 15 months than I've probably answered in the last 10 years of my career doing the same thing. So I think that was particularly useful for our patients when the time came. And again, I think this is my last slide. I think the key is it's working together. And again, my colleague Ken led this on behalf of the SARIC, but it's actually global research harmony. And we have to work together. And these designs allow large groups of hospitals and networks to collaborate together to answer questions quickly that our patients, our public, and our society needed at a time of great crisis. And I'd just like to thank everybody again. Thanks for the invitation. I have to particularly thank the healthcare workers who lent into this pandemic, the researchers who collaborated very unselfishly, and of course, our patients and our families for their participation and support. Thank you.